Assalamualaikum warahmatullahi wabarakatuh, and good day for everyone. Alright, so we continue with the basic radiographic positioning and anatomy, and go with the upper extremity, okay, which is the hand first. Alright, this is all your learning outcomes. At the end of the lectures, you have to able to be perform upper extremities of X-ray projections, okay, upper extremities, okay, and based on the video that I have placed in the LMS, and you have to see and very focus on the part of anatomy to be projected. Okay, be able to identify pathology reason on doing the examination. Be able to describe the structures, well, for example, showing the AP oblique of the wrist, for example. Okay, and then lateral projection. This is the basic one. State the correct positioning technique, the centering point. Okay, use of the correct equipment, SID, source to image distance. Okay, the marker itself, collimation, using the right collimation, as well as application of the radiation protection, for example, the contact shielding. And then you are able to describe a bit about the image evaluation, or other words, critiques based on the image or the radiographic shown. Alright, for this anatomy of hand, it consists of three parts. Okay, and all together consists of the wrist, the palm, as well as the fingers, right, and contribute to total of 37 bones. Okay, and it is divided to the wrist, which are 8 small bones. Okay, palm 5 bones, and finger consists of 14 bones. Alright, here comes the radiographic positioning. So we are learning about the basic projections of the hand. Consists of the dorsal palmar, PA, or posterior anterior view of the fingers, lateral view of the fingers, PA hand, oblique hand, wrist, and as well as the PA and lateral wrist. Okay, first is to see the fingers. Okay, it's about the fingers, or we call it phalanges. Alright, so it consists of 14 bones, 14 phalanx. It is closest to the metacarpal. The first row, call it as proximal phalanx. Second row, medial phalanx. Distal row, distal phalanx. And thumb is called pollex, as no medial phalanx, compared to from second to the fifth fingers. So the number is from 1 to 5, starting from the thumb itself. And then, okay, centering points, depending on what type of fingers. Okay, for the most of the fingers or phalanges, the centering point is at the proximal interphalangeal joint, okay, PIP. So we pointed here, D is the centering point for all of the fingers. Okay, we can see here A, distal phalanx. Okay, distal means distance from the that is not closer to the our body itself, so we call it distal. Okay, the interphalangeal joint here. Okay, proximal interphalangeal joint here, D. Okay, distal and proximal. Right, so this is probably the right side of the fingers projected. Okay, so for fingers, okay, we can see later and what is supposed to include for when you are projecting the phalanges, right, the correct way. So here we can see this fourth and fifth fingers radiograph, PA of fingers. Okay, pathology or indications that biasanya yang kita demonstrate basic projection for the fingers is fractures or dislocations. Remember, you have to differentiate between the fractures and dislocation. Okay, we will discuss it. Okay, ataupun you cari dulu what is the difference between the fractures and dislocation, how you want to differentiate it. Okay, types of fractures, for example. And then osteoporosis, a medical condition in which the bones become brittle and fragile from loss of tissue, typically as a result of hormonal changes or deficiency of calcium, vitamin D or vitamin D. Whereby for the osteoarthritis, it is a kind of inflammation and it involves joint disease. So the keyword is the joint disease. That results from breakdown of joint cartilage and underlying of the bone itself. So you have to know what is the osteoporosis and osteoarthritis. Okay, for the pathology, biasanya for upper lower extremities, if you mention the indications such as fractures, dislocation, okay, osteoporosis and osteoarthritis, it is kind of accepted lah. So kalau kata osteo here means involve the bone. So senang nak ingat osteo involve the bones itself. Alright, can you remember that? Okay, then go to next. Alright, okay, this one kita tengok beza. What is the difference? We have to know a bit about the common indication for the bones. Which one is osteoarthritis and which one is osteoporosis? Can you identify it for me? Okay, we'll discuss it and you can see there is a difference. You can see they involve the joint itself, okay, the proximal and distal, okay, the appearance, quite similar, but it's not so similar. Okay, there is a differences between for the pathology, okay, between left and right. So you have to decide that. PA fingers, the equipment, these all the technical factors that involve for the PA fingers, okay, posterior anterior of the fingers. So the first one is about the technical factors. The first is the cassette size, okay, imaging plate that you use, or image receptor. This is the same name. Usually we go for 10 times 8 or 10 times 12 inch of the image receptor. Sebab kecil je bahagian dia dah sangat kecil. Right, and then use of the sandbag. What is the purpose of using the sandbag? It's for the immobilization aids. Okay, and then lead protective waist apron or gonad shielding. It's the same lah. So for protection, we're gonna from the scattered radiation reaching the sensitive part of the patient. SID or source to image distance is 100 cm or 40 inch, and then fine focus spot in your setting. We want to go for the finest to see the bone structure, the trabecular markings as well, and anatomical markers too for the identification whether you are projecting the right side or the left side. Alright, exposure factor includes in the technical factors and usually suggested in between 45 to 48 kbp and 1.8 to 2.5 ms. Depends on the berapa tebal. Okay, kalau dia balut ke apa ke, you have to some sort of adjust the exposure factors, right? Okay, PA fingers positioning. Okay, positioning is said here, sit the patient at the end of the X-ray couch or X-ray tables. Place the palmar aspect of finger on image receptor and separate the fingers slightly. Include all fingers if possible to include either the thumb or the fingers, depending on what kind of projections. Immobilize the hand and wrist using the sandbag tadi, immobilization aids. Some more. Place anatomical marker left or right, collimate the beam and apply protection. Ask the patient not to move to stop breathing if necessary. This kind of positioning of the patient is needed to ensure that the radiograph we will produce without repeats, without artifact or somewhere else. Okay, so you can see here image A, B, C and D. Okay, so this kind of images projecting the fingers of phalanges, yeah, either it is second, the third, and sorry, fourth, third and fifth, right? Okay, what I can see here. Okay, this is all the centering point. The crosshair is mentioning about the centering point to be pointed. It is. Can you remember that? PIP. Okay. Before we go to centering point, I just want to highlight is that when you are projecting fingers, okay, one biasanya memanglah radiologist akan request for the doctors will request for the particular particular fingers, digits. So but then it is much more easier if you can include at least the part of the side by side fingers. For example, you want to project the middle finger, so you have to include at least the second and fourth finger. Okay, this is just suggested so that ataupun you mention somewhere, this is splitting technique that we use so that you can project it PA and lateral together in one imaging plate. All right. Centering point, as I said before, it is at the level of proximal interphalangeal joint of the fingers, and it is always perpendicular to the image receptor, ataupun vertical to 90 degree to image receptor. But right, so proximal interphalangeal joint. Okay, and then this is the image evaluation, and you have to know some image critics to learn about the critics of the image itself, whether, but you will be learning of more further in other modules that specified to the image evaluation of the radiograph itself. You'll be learning more details, but this is kind of basic. So now nampak dia masukkan sikit at least you masukkan a bit lah the other fingers, so that the radiologist when reporting they know that is confirmed it is a middle finger. Okay, for example here lah, sorry, this one is fourth finger. Okay, some sort of easy to for you to ataupun for the radiologist tu sendiri for reporting purpose. Right, so image evaluation here mention about the rotation of the digits, no foreshortening of the phalange. You know that is foreshortening or not by looking at the image itself, pointing to the joint, specifically distal, either distal interphalangeal or the proximal other the metacarpal phalangeal joint. The joint itself can some sort of indication whether this is supposed to be open space, joint space too. Okay, and then no soft tissue overlap from adjacent fingers. Remember, anything that you project is not supposed to be overlapping, even the soft tissue. This is the soft tissue, and this is the bone itself. Interphalangeal of the finger under involution must be open, as I said. Close or tight collimation of the affected fingers is recommended to include from the distal phalange through half of the metacarpal. At least we have to include the joint itself, and then close collimation ataupun tight collimation applied. You want to reduce the scatterization, so you have to properly collimate it. All right. Okay, go for the lateral fingers. Pathology is about the same. You can always, because a basic position is always AP and lateral, PA and oblique, PA and lateral, right? AP and lateral as well. So positioning, okay, depending on the fingers, the type of digits that you projected here, right? Splitting technique as well. So this one is obviously second. Okay, macam ni nak buat, you can do the other way around, but some can could be contribute to some more motion, okay, because of the stability of the patient itself. Some more, they go for this one, okay, much more closer to the image receptor, much more easier. So then even the use of the immobilization aids here, right? Some okay, to immobilize the patient, to make patient more comfort, right? This one is middle, okay, third digits, fourth digits, and the fifth digits. Okay, the D itself, D is the other way around lah, because the positioning, the comfort itself for the patient, easier for the patient to position the anatomy to be radiographed. Alright. So stand somewhere, flex underneath, not to include the so you flex the other fingers to avoid from the superimposition. Alright. Might as well placing the marker. And the centering point is same, it is at the proximal. So the third finger tadi, centering point is at PIP, proximal interphalangeal joint. Okay. Proximal interphalangeal joint. Yeah. Sorry, here it is. Proximal. And it is always perpendicular to the image receptor, directed perpendicular to the image receptor. Image evaluation here, same. How do you know it is non-shortenic? It's open joint space, okay, and it's not overlapping. If let's say it's a middle, cannot avoid lah. Some sort of soft tissue. Ensure that the soft tissue is okay, but not the bone itself to be overlapping. The anatomy, to see if there is any fracture. And good for the lateral is good for to look for the foreign body. Okay. And then the image is about the same. Contrast and density is good enough. Optimal contrast and density to visualize the part, the soft tissue and bone specular marking, as well as the pattern. Right, no motion appears. Seems looking at the bone itself, there's no motion. Right. Okay. Alright, it goes straight away to the epithumb. Okay, pathology can be seen is fractures as well. Bennett's fracture at the base of first metacarpal, osteoporosis, as well as the osteoarthritis. Right. So positioning epithumb. Okay, you can see here in the here. This is the cassette. This is placement of the epithumb, anterior posterior. Tadi kita belajar pasal PA. This one is entering the palm area, so it is an anatomical position. It is AP. Alright, for the this one, thumb here, AP or PA. This one PA. Alright, either one. Okay, you can project it as AP or PA, depends on patient condition. Okay, depends on the indication as well. Okay, if you want to project it as a APA, you have to use of the immobilization aids to ensure that patient is not moved. Okay, banyak cara sebenarnya. Alright, but this is kind of the contoh. Alright, so sama juga positioning dia. Alright, here. Thumb here. Centering point is at the first metacarpal phalangeal joint of the thumb here. This is the centering point, and it's always directed perpendicular to the image receptor. Okay, you can see the image evaluation is sama macam kita buat PA. You can see it's about the same of the appearance that we can see the soft tissue and the bone. Okay, separation, there is no overlapping of the tissues between the adjacent and there is no superimposition. Nampak ni macam ada fracture dekat this tempat ni. Tinggal letak marker. Right, this is indicates slightly soft but acceptable image quality. Alright. Okay, so pathology, fractures, sama juga macam tadi, macam sama macam tadi. So, okay, this is the positioning. Okay, set the patient the end, extend the hand. It is of PA specifically. Alright, sama juga you can project it. This is splitting. Okay, this is called as split. We projected PA here, and after that we projected another parts in the same cassette, in the same image receptor. Right, this is slightly different. Right, we're not using the mobilization aids just now we seen, but instead using a stick. Alright, the criteria for immobilization aids is that it's supposed to not to be seen in the radiograph. Okay, this macam ni macam ketembak, so it's okay lah, it's not projected, it will not appear on the radiograph. Okay, so this one says that the medial body of hand IR on the IR and rotate hand medially, and the palmar aspect is at the 15 degree to make sure it is true PA. Alright, macam biasa you have to extend and immobilization needs to be immobilize the patient lah. Right, we're going to put the anatomical marker as well. Okay, centering point macam tadi kata, first metacarpal phalangeal joint of the thumb. This is image receptor, same it's just that the positioning is the quite different between I mean the three of them. Okay, the image is supposed to be same appearance. Okay, but AP and PA is quite different lah, of course, but then the image quality is kind of the same. Okay, so this is to highlight the where's the placement, the interphalangeal joint itself. So distal part, proximal part. Okay. Centering point, first metacarpal phalangeal, MCP lah, first in metacarpal phalangeal. Okay, it's supposed to be here at the beginning, metaphalangeal joint. Alright, go straight away to the lateral thumb. Okay, this is the pathology, same thing, lateral thumb. Okay, so how do you position? Just now we were doing the PA or AP. Okay, palm up or palm down. Okay, so this one is lateral thumb, slightly you just letak aja. Okay, but then you have to apply some sort of immobilization aids or the pad, kind of foam pad, to ensure that the patient is in the lateral. Okay, extend the patient hand and wrist. Extend. How high do you have to extend to ensure there is no overlapping of the region of interest. Okay, wrist palm on the pad until thumb is introlateral, immobilize as well. Put on the anatomical marker. Okay, kalau boleh this anatomical marker should be kind of atas sikit lah, jangan sampai you kena dekat area of interest ni. Alright. Centering point is the same. First metacarpal phalangeal joint, and it's always directed perpendicular to the image receptor. Okay, image receptor. This is the appearance to be seen. Okay, soft tissue as well as the bone itself. Okay. First digit into lateral, thumbnail visualized and normal in profile. In profile means you can see clearly, see through. You can see it without overlapping between two tissues, between two region of interest between that means no overlapping. This is called in profile. Alright, no rotation of the phalanges, area of the distal tip of the thumb to the trapezium. Here open interphalangeal joint. You have to make sure that it's the open interphalangeal joint. So we can say there's no this is correct projection lah. Okay. In soft tissue, bony tubercular markings is well visualized. Okay, what is soft tissue here? Bony tubercular marking is the one inside the bone itself. Right? Cortical outline is this one, the white one. The marking is inside the bone. Pattern. Bony tubercular marking, bony tubercular pattern is the same. Right? Okay, go for the PA oblique of the thumb. Okay, tadi kita PA or AP, and then lateral, and go to oblique. Okay. Oblique ni macam you letak saya terangan, without the immobilization aids apply. Tadi true lateral, this one is kind of just place on the palm close to the image receptor. Okay, as in the cassette. This is the crosshair indicating the centering point. Right? Okay, so summer. Centering point is at the first metacarpophalangeal joint and directed perpendicular to the image receptor. Okay. Image evaluation is about the same with just now the PA or AP. As well as the lateral. Okay. So metacarpal bones, just to see the dimension. Palm metacarpals. Okay, ingat tak mula-mula tadi kan? Carpal, metacarpal, and phalanges. Alright, phalanges is the fingers, the carpal is the wrist, metacarpal is the palm itself. Okay. Okay. We finish about the fingers, the phalanges, okay, the thumb as well. So we straight away to the hand after this. Alright, go straight away to the PA of hand, posterior anterior of the hand, pathology or indication. We can see here we have fractures, dislocations. Okay, there is a difference between fractures and dislocation. You have to note that. Foreign bodies of the phalanges, metacarpal, or other joints of the hand, osteoporosis as well as OA, osteoarthritis. Right. And then equipment required. The technical factors includes the exposure factors, which is range of 45 to 50 and 2 to 5 mAs. Alright, so the size of the image receptor usually use of the 10-12 split into two, splitting methods, and then sandbag as an immobilization, repetitive waist apron or gonad shielding. SID is 100, fine focus spot is used, and anatomical marker. This is the positioning of the hand. You can see here the put of the palm, okay, on the image receptor. Okay, and you can see here, as usual, you are putting the patient at the end of the table couch. All right, flex the elbow about 90 degree. Okay, the elbow here. Okay, flex it 90 degree. Okay, for comfort of the patient. Rest the forearm and wrist on the table together in the same level of the your armpit. To make sure that your table is at the same level of your armpit. For flex the elbow about 90 degree, rest forearm, and place palmar aspect of the hand on the IR to include wrist joint. Okay, remember that most of the extremities you have to include joints, one or two joints. Extend the fingers, separate it slightly, okay, to avoid from what we call that superimpose, okay, between the fingers. Immobilization of arm using the sandbag, okay, or immobilization aids, as well as to place the marker here, and not to forget about the gonad shielding to be applied as a radiation protection to the patient. And then centering point. Okay, the centering point of the PA of a hand is at the third metacarpals, and direction is always perpendicular to the image receptor. Image evaluation you can see here. Alright, you can see the difference between the soft tissue area and the bone itself. Okay, mentioning about telling us it is adequate enough of the contrast and density. The exposure is just fit there. You can see both the soft tissue area as well as the bone. Okay, the vertical outline itself as well as the cervical marking. Right, you can see here the entire hand, about 1 inch of distal forearm are visible. Okay, this is the forearm. Part of the forearm include the joint itself. Okay, so you are projecting full PA of the hand, okay, without any cut off or superimpose in between the soft tissue as well. Then demonstrate oblique of the thumb. Okay, you can see obliquely of the thumb here compared to others. MCP joint, metacarpal phalangeal joint, and IP joint should be open, area of the joint itself. No rotation, symmetric appearance of both sides or concave. The amount of soft tissue on each side of phalanges appear equal, and no motion appear. Okay, with you can see the sharp trabecular marking here. Kalau tak dia blur. Alright. Okay, go straight away to the hand. Sorry, to the oblique. Pathology demonstrated. Same thing. Fractures or dislocation, osteoporosis or arthritis is acceptable. Then the positioning itself, okay, either you are using the immobilization aids or you yourself position the hand itself as an oblique. Okay, kind of a bit macam kita nak ambil sesuatu tu. Right, sit the patient at the end of the table. Extend the hand, okay, to ensure there is no overlapping. And then place the palm of hand on IR to include the wrist joint, sama macam PA hand tadi. But you will raise the thumb until palm is at 45 degrees from the fillet. Adjust the palm itself. Reaches 45 degree about oblique. Ataupun that's why I kata you pakai the immobilization aids 45 degree. Okay, separate and slightly flex the fingers and thumb and support on the pad. The pad is referring to the immobilization is then we use lah. And then not to forget the anatomical marker as well as the connection link. Alright, centering point is at the third metacarpal phalangeal joint. Okay, and direction is perpendicular as well. Ataupun vertical nanti pergi to the image receptor. And image radiation should appear like this. Okay, slightly different from the PA. Okay, remember because we are projecting the oblique view instead of a PA. PA. Okay. So the center itself. Okay. Indicating no motion, just enough to include this one. Okay, entire hand and wrist about 2.5 cm distal forearm are visible. Okay, we'll include the joints. Remember to include the joints. Okay. Okay, learning for the bones itself for couples. Okay, other open wrist, more specific to the wrist. Okay, you can see here couple bones. Right. Consists of the pisiform, triangular, lunate, hamate, cubital, scaphoid, trapezoid, and trapezium. Okay, my lecturer used to say about this acronym. You have to create the acronym lah. The suggested here. Before this, I learned about acronym about she looks too pretty. Try to catch her. Some sort of that acronym. For example, like she's scaphoid, looks lunate, too pretty, trapezium and trapezoid. Try to catch her. Triangular, cubital and hamate. P I don't remember lah. But there is a acronym to for you to remember lah, easier. Okay. Alright, in the top row here, the closest to the forearm to the four bones is here, the pisiform, triangular and scaphoid. And it's another part of the second row made of four bones from the medial to lateral side. Nampakkan lapisan dia tu, ini lapisan ni yang mana yang medial, which side is lateral. Alright, for the wrist or carpus, 8 small bones, carpal bones. The top row is from the lateral, start from the thumb, yang closest to the thumb, which is the scaphoid, the medial. Scaphoid is the most bigger lah, larger for all the carpals. Mid, trachea, and pisiform. Second row from lateral to the medial, trapezium, trapezoid, capitate, and hamate. Okay, for learning more details for this kind of the bones itself specific, because wrist is the one yang biasanya yang kita kena fracture so they got specific projection we will learning in IS2 next semester. So for wrist, it is PAN, lateral, the basic projection, posterior, anterior, and lateral. So pathology is about the same like others. Okay, fractures maybe more specific to the radial side, ulnar side, stellar, styloid process to radial or distal radius ulnar as well. Fracture for individual carpal bones itself, for example, the scaphoid, and you get a specific projection for that actually. So before you go for the specific or additional, we always go for the basic projection, remember that. So and then yang lain sama boleh jadi juga osteoarthritis or osteomyelitis. And equipment is about the same. Splitting can be split due to the parts quite small. And the cassette or image receptor selected is 10-12 inch. Sandbag, and it's about the same. SID is always 100. For upper and lower extremities, go for 100 cm. Okay, SID. And the technical factors, this is all the technical factors. And exposure factors suggested is in between 50 to 55 kbp and G to 5 ms. And then positioning, okay, based on the based on the image itself here. Okay, pointing to the here. This is the middle wrist. Okay, and this they apply split up the cassette. Okay. Again, you visiting patient at the end of the table. Wrist palm and wrist lower forearm in the straight line. Where is the line with the IR? You have to apply the aesthetic value here. Sebenarnya for the radiograph actually. Right, place the small pad under the MCP of the hand if needed, and place the anatomical marker as well as apply the gonad shading ataupun apply the protection to the patient. Okay, it kind of grabs the cassette itself to make sure the placement of your wrist. Okay, this is PA, which is centering point here. It is midway between the ulnar and radial styloid process. You can say it is mid wrist here. Okay. I can accept if you mention the midpoint of the wrist, and it's always directed perpendicular to the image receptor. This is the image relation pointing all the bones, small bones here. Okay, you can see here closest to the thumb is the scaphoid, pisiform to the lateral side. This is called you have to make sure the part of the ulnar, radius ulnar is included as well as the upper side. Kita kan boleh tahu centering point tu betul it is in the center when you do the cross. Cross, like cross, imaginary line cross. Kalau betul dia punya crosshair tu, yes, this is exactly at the middle. Okay, this is kind of just to ensure lah. Alright, so this mention about long axis of the hand, wrist and forearm is aligned. So collimation, tight collimation apply include the soft tissue like in lateral side and 4 collimated area ni. Equal gravitation of each side of shaft of the proximal metacarpals and near equal distance among the proximal metacarpals. Separation of distal radius ulna is present. Part of the distal ulna is present and part of the proximal metacarpals is included in the radiograph. Not to mention, you can see the left marker here. Okay. Bilateral demonstrated for the lateral wrist. Pathology is about the same as well. You can see, and specific to buttons, Colles or Smith type of fracture. Okay, go search for this kind of fracture. We'll discuss later. Okay, when our session in the later session. Okay. And as well osteoarthritis primarily in the trapezium and first metacarpal joint. CMC is carpal metacarpal joint. And lateral side, this is the projection. Okay, placing of the marker, and then you place immobilization aids here. Okay, so macam biasa you have to sit the patient at the end of the table, extend the hand, wrist, and forearm to make sure the wrist, the part itself is in straight line. Aesthetic value to be applied, and as well as the straight line here. So you want to ensure that it is straight. You kind of place the immobilization aids for guidance to the patient. Take the forearm into the lateral position. Rest the fifth finger on the cassette, always close to the IR, to the image receptor. You can feel the both radial styloid and ulnar process too. Ulnar and radial styloid process too. You have to make sure it is in contact and it's not rotated tilt. Okay, yeah. You can feel the bone itself. Okay, and place the marker. As well apply the anatomic radiation protection lah. Apply the gonad shielding for this case. Centering point is always radial styloid process. You can see in a midpoint. I can accept as well or proper steroid to the radial styloid process, and always pointing to the directed to the perpendicular to the image receptor. Okay, this is the image to be seen in the radiograph. Okay, make sure marker is not in the side of anatomy here. It's supposed to be it's a bit outside. Okay, ni yang saya kata tu, you have to mention, you kena masukkan, and you have to be superimposed. Ni dalam cerita ni, dalam race ni cerita dia, you have to make sure it is superimposed. Itu baru true lateral, perform the true lateral position of the wrist. And then proximal second through fifth all should be appear aligned and superimposed. Nampak dia align and superimposed. Termasuklah yang thumb ni kan, yang saya letak kan. First metacarpal, so the others ni yang you make sure that it's straight line lah. Sama macam ni. Indication as well the radius ulnar ni. Part of it, this part. Proximal part. Okay.